Let's bypass the pleasantries and jump straight into the clinical material for today's explainer. Pregnancy acts as an intense cardiovascular stress test, one that absolutely can and will unmask severe underlying pathologies in your patients. We're treating this session as an integrative mixed block simulation. The target? A perfect 270+ score. So let's maintain a strict, peer-to-peer professional focus as we break down these intricate mechanisms.
Here's our clinical syllabus. We're going to hit the hemodynamic surge, valvular unmasking, heart failure restraints, and finally, the hypercoagulable state. Let's get into it.
Part 1. The hemodynamic surge.
A normal pregnancy triggers a massive hemodynamic surge. You've really got to conceptualize this as a state of physiologic volume overload. We're talking about maternal plasma volume expanding by a staggering 50%, mostly during the second trimester, and peaking right around that 28 to 32-week mark. To handle all that extra fluid, the maternal cardiac output has to compensate with a 20 to 30% increase.
Visually, the chronobiology of this surge is pretty striking. Stroke volume ramps up to its absolute maximum at 19 weeks. Meanwhile, the maternal heart rate is gradually ticking upward, allowing the total cardiac output to rapidly rise by 20%, and then it peaks with an additional 10% increase by 26 weeks. Listen, this timeline is non-negotiable for your exams. Knowing exactly when the system faces maximum mechanical stress dictates exactly when these underlying pathologies are going to present.
Section 2. Valvular unmasking.
So what happens when this 50% volume surge hits a structurally flawed system? Previously asymptomatic, mild to moderate rheumatic mitral stenosis is suddenly unmasked. As that massive plasma volume surge hits at the end of the second trimester, it drastically increases the transmitral pressure gradient. That stiff, calcified mitral valve just cannot accommodate the flow. The result? Acute left atrial dilation and retrograde pressure backing up directly into the pulmonary vasculature. You've got to rely on precise acoustic markers to catch this at the bedside. Look for a loud S1, followed by a crisp opening snap, and then a distinct, low-pitch, mid-diastolic rumbling murmur. You're going to hear this best at the apex with the patient in the left lateral decubitus position. And whatever you do, don't confuse this with the benign systolic flow murmurs that are universally heard in normal pregnancies.
Let's test this with an integrated assessment. How do you mentally isolate pathological mitral stenosis from normal physiologic dyspnea? Here's the scenario. A 30-week pregnant patient presents with new-onset severe orthopnea, bilateral basilar rales, and a normal left ventricular ejection fraction. Is the diagnosis A, normal physiologic dyspnea of pregnancy, B, aortic regurgitation, C, peripartum cardiomyopathy, D, rheumatic mitral stenosis, or E, primary pulmonary hypertension?
The correct answer is choice D, rheumatic mitral stenosis. Let's exhaustively break down why. Choice A is out. Physiologic dyspnea doesn't produce bilateral basilar rales or orthopnea. Those are hard clinical signs of flash pulmonary edema. Choice B, aortic regurgitation, presents with a blowing diastolic decrescendo murmur and a widened pulse pressure, and it's not typically unmasked with flash edema mid-pregnancy. Choice C, peripartum cardiomyopathy, is strictly a systolic dysfunction that presents in the last month of pregnancy or postpartum with a reduced ejection fraction, but our patient's EF is preserved. Choice E, primary pulmonary hypertension, causes right-sided failure, so you wouldn't see the left-sided pulmonary edema we have here. The absolute key is that preserved ejection fraction. The structural blockade at the mitral valve is forcing that increased fluid volume straight back into the lungs.
Moving on to Section 3, heart failure restraints. Let's transition from preserved ejection fraction to the severe kinetic decline of systolic heart failure. Unlike the valvular unmasking we just looked at, new-onset systolic heart failure, like peripartum cardiomyopathy, presents with a severely depleted left ventricular ejection fraction of less than 45%, alongside profound cardiac remodeling. Timing is everything here. This occurs strictly in the final month of pregnancy or within 5 months postpartum. The ECG changes and hypertrophy you'd see are the electrical manifestations of a failing, dilated pump.
Now, the pharmacological management here parallels standard heart failure, but you have got to memorize this strict matrix of absolute teratogenic contraindications. You are walking a clinical tightrope. ACE inhibitors, ARBs, and ARNIs, they are completely off the table. Instead, you must utilize hydralazine, nitrates, and cardioselective beta blockers to optimize her hemodynamics without destroying fetal perfusion.
Critically, we need to understand the precise mechanism of harm here. ACE inhibitors and ARBs are strictly forbidden because they directly block the fetal renin-angiotensin system. If you give these, you cause fetal renal tubular dysplasia, which results in severe oligohydramnios, neonatal renal failure, and subsequent pulmonary hypoplasia.
Bottom line, it is an absolute contraindication, no exceptions.
Your discrete management steps require you to rapidly identify that S3 gallop, completely bypass standard guideline-directed medical therapy like those ACE inhibitors, and safely lower the systemic vascular resistance using pregnancy-safe afterload reducers like hydralazine or nitrates. Let's put that into practice with our next 5-choice integrated assessment. A patient at 38 weeks gestation presents with an S3 gallop, peripheral edema, an LVEF of 35%, and a hypertensive crisis blood pressure of 160/110. Which pharmacological path do you take? A. Intravenous enalaprelate. B. Sacubitril/valsartan. C. High-dose spironolactone. D. Furosemide monotherapy. Or E. Labetalol or hydralazine.
The definitive answer here is E, labetalol or hydralazine. Let's dissect the traps. Choices A and B are ACE and ARNI derivatives. Giving these will cause lethal fetal renal dysgenesis. Choice C, spironolactone, is antiandrogenic and generally avoided in pregnancy, plus it's not going to rapidly fix a hypertensive crisis. Choice D, furosemide monotherapy, while useful for volume offloading, won't adequately address that severe systemic afterload and actually risks aggravating the low plasma volume to the point of uterine ischemia. This clinical scenario dictates immediate initiation of labetalol or hydralazine to drop the afterload while carefully maintaining uteroplacental blood flow.
Let's hit our final block. Section 4. The hypercoagulable state.
Even when hypertension is well controlled with something like labetalol, the underlying endothelial environment is violently shifting. This places the patient at immense risk for preeclampsia, a condition that is fundamentally driven by abnormal placental spiral arteries and poor trophoblastic invasion.
The data shows us a deliberate, progressive shift towards systemic hypercoagulability as the patient approaches term. This is driven specifically by increased procoagulant factors and decreased protein S. Physiologically, this is an evolutionary safeguard against exsanguination during placental separation, but clinically, it renders the postpartum period the absolute highest risk window for venous thromboembolism.
Conditions like preeclampsia drastically exacerbate this state. That poor trophoblastic invasion leads to placental hypoperfusion, which then dumps vasoactive hormones into the system. This triggers generalized maternal endothelial dysfunction, severe vasospasm, and an exaggerated systemic hypercoagulability that puts your patient at extreme risk for life-threatening clots.
Which brings us to our final integrated clinical assessment. This is a third-order diagnostic scenario. A 4-day postpartum patient suddenly develops sharp, pleuritic chest pain, severe dyspnea, and tachycardia. Lung auscultation is completely clear. The ECG shows new onset right axis deviation. What is the most appropriate next step in management? A. Order a screening D-dimer assay. B. Reassure the patient this is normal postpartum physiology. C. Administer empiric low molecular weight heparin and order a V/Q scan. D. Initiate oral ACE inhibitors for peripartum cardiomyopathy. Or E. Proceed directly to open surgical embolectomy without imaging. The correct answer is C. A massive pulmonary embolism is evolving right in front of you. Let's break down the exact clinical logic. Choice A is a classic trap. D-dimer is physiologically elevated in all normal pregnancies and postpartum periods, making it entirely useless here. Choice B is frankly negligent. Sudden dyspnea with clear lungs and right heart strain is a PE until proven otherwise. Choice D ignores the clear signs of right heart strain and pulmonary pathology in favor of a contraindicated drug. And choice E is a severe overreaction before confirming the actual clot burden. You must immediately administer empiric low molecular weight heparin due to the high clinical probability of a pulmonary embolism, and then proceed with diagnostic imaging. While CT pulmonary angiography is valid, a V/Q scan is highly utilized in this population to minimize radiation exposure to breast tissue and the neonate. Master this diagnostic pathway. End of simulation.